Thank you, and thanks to the organizers for inviting Cytokinetics to participate in this conference. It has been great, and we've enjoyed it to date. We've been texting each other about how good it's been. So I'm going to be talking today about reldesemtiv, which is a small molecule that works at the level of the sarcomere. The way muscles contract is that thick and thin filaments have to slide past each other. And in order to do this, the myosin head has to attach. And this can't happen if the filaments are in a relaxed state. But when calcium binds to troponin C, it unwraps and changes the configuration. It allows that myosin head to attach, and they thin and thick filaments slide past each other, which is what happens as we contract our muscle. How reldesemtiv works is it increases the affinity of troponin C for calcium. And as a result, in preclinical studies, reldesemtiv has been demonstrated in response to nerve stimulation to increase skeletal muscle force that's generated, in addition to delaying when fatigue occurs and the degree of fatigue that occurs with repetitive nerve stimulation. So in FORTITUDE-ALS, which was our phase 2 study of reldesemtiv, we included patients who had been diagnosed within 24 months, had a vital capacity of at least 60%, and were permitted to be on stable riluzole and/or edaravone. We randomized in equal numbers to one of 4 treatment arms, 3 doses of reldesemtiv and placebo. The main outcome measures that we were interested in tracking were vital capacity, the ALS FRSR, and muscle strength. And in this study, muscle strength was done in large and small muscle groups in the arms and legs through HHD testing. Following screening, eligible patients were randomized and received reldesemtiv or placebo for 12 weeks, and then they had a follow-up visit 4 weeks after the last dose taken. Our primary endpoint was the change from baseline in percent predicted in SBC at week 12, and this did not reach statistical significance. But what you can appreciate in this graph is that all 3 doses of reldesemtiv had less of a decline in vital capacity compared to those patients on placebo. Secondary endpoint included the change from baseline to week 12 in the ALS FRSR. And again, we did not reach statistical significance. But once again, you can appreciate that the patients on all 3 doses of reldesemtiv had less of a decline in the ALS FRSR score compared to those on placebo. Given that we were seeing evidence that all 3 doses had some benefit from being on reldesemtiv, in a post-hoc analysis, we combined all patients on any of the 3 doses of reldesemtiv and compared those to placebo. And on the left, you can appreciate that there was a relative reduction of 27% in the decline in slow vital capacity for those on reldesemtiv compared to placebo. And then on the right-hand side, we looked at the ALS FRSR in a similar fashion and found a relative reduction of 25% in the drop of the ALS FRSR for the combined reldesemtiv treated participants compared to placebo. We also looked at an exploratory endpoint in this trial. It was the probability of being prescribed and agreeing to receive an item of durable medical equipment. And we were in particular interested in 5 items: a manual wheelchair, a power wheelchair, non-invasive ventilation, augmentative language device, or a PEG tube. And we looked at the time to agree to receive it rather than the time it was obtained, given the short duration of the trial. We did find that patients on reldesemtiv had a 38% lower risk of agreeing to receive a new DME item compared to those on placebo. And this is something we'll be exploring further in a more elaborate fashion in our COURAGE-ALS trial. The treatment emergent adverse events that occurred in 10 or more patients are shown in this table. 2 clinical adverse events are boxed out because they did seem to occur in higher numbers of people on active drug, that is fatigue and nausea. And then the other thing that's boxed out is the laboratory adverse events. We use cystatin C to calculate the eGFR, and did find that patients in a dose-dependent fashion were more likely to have a decline in eGFR if you were on reldesemtiv compared to placebo. And similarly, ALT and AST increases were seen more in patients on reldesemtiv than on placebo, and these two were seen in the highest numbers of patients for those on the highest dose. Overall, regarding safety and tolerability, we had similar incidents of early treatment discontinuation, serious adverse events, and clinical adverse events when looking at placebo and active arms. Nausea and fatigue were the most common clinical adverse events reported, and there were lab findings related to liver and kidney function that were seen. They trended towards resolution after study drug was discontinued, and it did inform us regarding dosing for our COURAGE-ALS trial. We are going to be using 300 milligrams twice a day in that study. So as we heard yesterday in some of the talks, everybody has an interest in identifying clinical features that may be associated with a higher likelihood of seeing a benefit. And we did subgroup analysis related to the ALS FRSR total scores. And we did identify certain clinical features that were associated with a more robust treatment effect. And these included patients who had symptom onset less than 2 years. If you recall, we used time to diagnosis, although we also recorded symptom onset. And those with shorter symptoms tended to fare better. We also looked at pre-study disease progression rates, and we used the standard formula for determining this. We took their ALS FRSR score at baseline, subtracted it from 48, the maximum score, and divided that number by the ALS symptom duration in months. And then we divided these into thirds. The thirds included the patients in the groups with the middle and fastest rates of pre-study disease progression did show a greater difference on reldesemtiv compared to placebo, in contrast to the patients in the slowest group. And I think we all have come to appreciate that if you're progressing very slowly at study entry, because you happen to be a patient who does that on their own, then they're going to change very little over the course of a trial, particularly one like this, which was only 12 months long. And so they would potentially not be able to contribute much to detecting a treatment effect. As a result, we then did post-hoc analysis and looked at all patients in the original population of FORTITUDE-ALS, and those are the column A, or the gray column. And then a subgroup of those patients are seen in column B, and those are patients who had symptoms within 24 months and had a maximum ALS FRSR score at baseline of 44. By doing it this way, rather than going based strictly on that ALS pre-study disease progression rate, we believe we will minimize but not totally exclude slow progressors. And you can see that in this study, in this post-hoc analysis, by doing this, we did identify a patient population that demonstrated a larger effect size with improving p-values. So this has helped us in designing our current trial, which is COURAGE-ALS, which is currently enrolling patients. And this shows the overall schematic for COURAGE-ALS. I talked before about how we ended up with some of the ALS related criteria, the symptoms no more than 24 months, and the total score no higher than 44. We also upped the vital capacity a bit to 65%, given that this is a longer duration study. Our goal is to randomize approximately 555 patients. They'll be stratified according to riluzole and/or edaravone use. And they'll be randomized 2-to-1 in favor of reldesemtiv. The dose, as I mentioned before, will be 300 milligrams twice a day. The first 24-week period is a double-blind placebo-controlled phase. And then from 24 weeks onward, all patients will be on reldesemtiv. And then there is a 4-week follow-up after the last dose taken. In the bottom half of the screen, you can see the overall study visits played out, and they're color-coded. The green arrows indicate ones that are done in clinic. The blue arrows are done remotely. And then you'll notice that we do FVC at times only remotely, but at other times they're done within a few days of each other, both in clinic and in a remote circumstance. And all patients are provided a mobile phone and can have video calls to have the remote visits performed. You can also see that our focus in terms of outcome measures will be the ALS FRSR, forced vital capacity, the 40-item ALS specific quality of life outcome measure called the ALSAT Q40. We'll be doing somewhat limited muscle strength testing in this study. We're going to limit it to hand grip and then HHD testing of intrinsic hand muscles. And then we'll be obtaining lab essentially monthly. I've already talked about some of the key inclusion criteria, but others include patients have to be diagnosed with ALS, and this is pretty broadly interpreted per Ellis Scorio criteria. The only group that we are excluding are patients with pure upper motor neuron features, those that we refer to as PLS or primary lateral sclerosis. The age range is fairly wide, 18 to 80 years old. We are enrolling patients with both sporadic and familial ALS. I had mentioned that symptoms have to be within 24 months, but we do note that cramps, fasciculations, or fatigue and isolation are not considered symptoms. The ALS FRSR score can be rescreened if it is too high, and we do permit riluzole and edaravone, and patients need to be able to swallow whole tablets at screening. Our primary endpoint is changed from baseline to week 24 in the ALS FRSR total score, and the secondary endpoints are four in number. The first one is a joint rank test. It's a somewhat modified version of the traditional CAVS. We include in that ranking the ALS FRSR total score, but also the need for respiratory assistance as well as survival at week 24. And then our other secondary endpoints are change from baseline to week 24 in percent predicted FVC, change the ALS at Q40, and the hand grip strength. We have 2 interim analyses planned. The first one will be timed such that it will occur about 12 weeks following a third of the planned patients having been randomized, and it is done for futility purposes. And then the second interim analysis is performed when approximately a third of the planned patients time-wise would be at week 24, and it asks not only is the trial futile, but it also asks the question, is the trial adequately powered? And if it looks promising, but there's concern that the planned number of patients may make that difficult to determine, there is the possibility of adding an additional 150 patients. This is a phase 3 registrational trial, and we're hopeful that the inclusion criteria, which we determined based upon what we learned from our phase 2 trial, have helped to identify patients who are most likely to be able to demonstrate a benefit from reldesemtiv. It's an oral drug. Unlike many ALS trials, we are permitting non-invasive ventilation use at screening. This is both true for CPAP that the patient may have been on for years for obstructive sleep apnea, but also bilevel NIV prescribed for their ALS. We've tried to make the trial design patient-friendly. About half of the visits are performed remotely. We have a 2-to-1 randomization in favor of receiving active drug, and all patients will be on reldesemtiv in the second 24-week period. We are also committed to continue to provide access to reldesemtiv for those who complete the trial, assuming that interim analysis and trial results support its continued development. And I'm happy to take any questions.
Thank you very much for that fantastic presentation and clear articulation of using previous trials data for your design of your next trial. I had a question myself right off the bat, and I hope I caught the data correctly. It looked to me like in the FORTITUDE trial that the effect persisted during the 4 weeks following when patients were no longer on drug. Yes. Did you expect that given the mechanism of action? And does it mean that the support of muscle function while on drug ends up producing muscle that remains functional over time?
Did we expect it? Yes and no. And I say yes and no because we have seen that with our first generation fast skeletal troponin muscle activator, tirasemtiv, in a phase 2 trial. And we saw it in an SMA trial in the 6-minute walk test that we did with reldesemtiv. And so we had a history suggesting we might see it. We were happy to see it because it does suggest that it may be a disease-modifying drug in some way. And we currently have some preclinical studies in the planning phases to try to look more at that in the animal models.
Yeah, thank you. I'll go to the chat now to mine for questions. Is there, sorry, it just moved. Is there specificity of reldesemtiv for skeletal muscle?
Yes.
Okay. Please.
Yes, and I saw my colleague answer too. Yes, it's specific for skeletal muscle. So we don't have any crosstalk with cardiac muscle.
And is there any postsynaptic calcium decrease due to excitotoxicity here, or is this very specific to the muscle?
It's very specific to the muscle. I'll also add, we didn't, one of the things that came out with when we were doing tirasemtiv that FDA was concerned about, that it could increase spasticity, kind of overly produce something. And so in prior in the prior study with reldesemtiv, we did the Ashworth, and we saw no evidence that it was different between patients on placebo and active drug.
Well, thank you very much for the
Thank
fantastic
you.
presentation. And